Good morning. Good
Good
morning,
morning, doctor.
everybody. Good morning. So welcome to the weekly Cardiology Fellows Seminar. Today we will be having an interesting summary on landmark studies of renin-angiotensin-aldosterone inhibitors in heart failure. It will be presented by Dr. Mulualem. So the floor is yours, Dr. Mulualem. Can start, I think.
Thank you, doctor. As has been said, this is a presentation on RAAS system inhibitors mainly in heart failure, and these are the outlines of my presentation. I will say a few things on the discovery of RAAS, and then talk about the summary of the landmark trials in heart failure with reduced ejection fraction, and I will say a few things on post-MI LV dysfunction, and also I will have a slide or two on RAAS inhibition in stable coronary artery disease and heart failure with preserved ejection fraction. The discovery of RAAS and drugs inhibiting that system spans around a decade to this date, and RAAS initially renin was discovered in the end of the 18th at around 900 by Swedish scientists, and then subsequently drugs inhibiting that system and the other parts of that system were discovered, and the drugs inhibiting RAAS have been described as among the top 10 advances in cardiology by Eugene Braunwald, and that is together with beta blockers, statins. These three drugs have been among the top 10 advances of cardiology, just like the ECG, the cath lab, and other very important discoveries because of the significant impact they have on outcome of patients with heart failure. And the initial AC inhibitor was discovered from the pit viper venom, and it was the original AC inhibitor which was discovered from this snake that you see on the screen, and subsequently synthetic preparations were made which modified the property of this indigenous AC inhibitor. And as you can see here, the RAAS system and the natriuretic peptide system are closely interrelated, and the significance of renin, angiotensin, aldosterone 2, and the effects of aldosterone 2 on the type 1 receptors have been incremented in many of the worst outcomes related to heart failure, and the neprilysin pathway, which degrades the natriuretic peptides, and as well the angiotensin 2 has also been incriminated in the pathophysiologic pathways of heart failure with reduced ejection fraction, and inhibiting this pathway has been the corner of treatment in patients with heart failure with reduced ejection fraction. And the discoveries around this RAAS system are continued in the recent years as well, with further degradation of products of angiotensin 2 having significant physiologic effects. When we see the chronology of landmark trials in RAAS inhibitors, it started with a consensus trial, as you know, in 1987. It was a Scandinavian trial, and it has gone all the way to the paradigm heart failure trial, which was published a few years back, which shows the efficacy of ARNI in heart failure. So when we talk about RAAS inhibitors in heart failure with reduced ejection fraction, we talk about AC inhibitors, angiotensin receptor blockers, aldosterone antagonists, the ARNIs, and I will have a few things on the dose of RAAS as well. So AC inhibitors in heart failure with reduced ejection fraction, there have been two trials evaluating this in patients with symptomatic LV dysfunction, and another trial on asymptomatic patients. The consensus trial, as you know, was a trial for patients with severe heart failure, and the solver treatment trial was a trial for patients with milder form of heart failure. And the consensus trial, which was the first and the most important trial, it was a relatively small scale trial involving only class for patients for whom the annual mortality rate by that time was around 50%. And the trial enrolled around 253 patients and continued for around 6 months. And by 6 months, it was able to show the significant efficacy of AC inhibitors in preventing major worse outcomes. And as you can see in the baseline characteristics, all the patients were matched for almost all relevant features. And the main cause of heart failure, as in most of the subsequent trials I have presented, is ischemic heart disease. And concomitant therapies during that time included mainly diuretics and digitalis. And when we see the outcome, there was around 27% reduction in total mortality. And this trial was set out to look at improvement in mortality mainly. And the difference in mortality was significant, starting from 6 months. And for patients who continued the study for a longer time, the difference was significant till the end of the study. And the main mode of reduction in mortality was via decrease in mortality related to progressive heart failure. And there was no significant difference in sudden cardiac death between the two groups. And the adverse events, since the trial was a small one, no significant difference between adverse events was seen in this treatment. The other treatment published years later is the studies of left ventricular dysfunction in heart failure trials. And it had two arms, the treatment arm and the prevention arm, as I said earlier on. And the treatment arm encompassed around 2,500 patients, and the patients were matched for all the baseline characteristics as you would expect. And most of the patients are class 2 and class 3 patients. So it was a study of milder heart failure trial compared to the consensus trial. And as you can see, that there was significant improvement in all-cause mortality, reaching around 16%. And similar to the consensus, the reduction in mortality was mainly via reduction in progressive heart failure. And there was no significant difference in days related to sudden cardiac arrest. And besides mortality, the combined endpoint of mortality and hospitalization individually was significantly improved in this trial. The subsequent trial or the trial which was published together with the treatment trial was the solvent prevention trial, and it encompassed patients with LV dysfunction but without symptoms of heart failure. And the outcomes, there was a trend towards reduced mortality, but that was not statistically significant. And the combined endpoint of days plus hospitalization or days plus development of heart failure was significantly reduced with a treatment arm in patients with asymptomatic LV dysfunction. So these are the main trials with AC inhibitors in heart failure with reduced ejection fraction. And more significant improvement in outcome was seen in patients with in the lower range of ejection fraction in solvent prevention as well as treatment trials. And the other is about angiogenesis receptor blockers in heart failure with reduced ejection fraction. And the premise was we know that the ARBs are more tolerable than the AC inhibitors. So blocking the RAAS system without much side effects was thought to be possibly helpful. And the complete blockage of final common pathway of angiotensin 2 binding its type 1 receptor was deemed helpful. And there are alternate pathways to the RAAS system which could generate the angiotensin 2, like the Chinese pathway, and blocking the final common pathway was thought to be more helpful. And people tried that, and the effect of angiotensin 2 on its type 2 receptor was shown to be helpful, and with increased availability of angiotensin 2 with that could bind to angiotensin 2, significant benefits were expected, and people went on to try that. And there were three ways of trying the role of angiotensin receptor blockers. The first one, it was direct comparison with AC inhibitors. The others are for angiotensin receptor blocker in AC intolerant patients, and the final was combination therapy with AC inhibitors and ARB. And initially, the ELITE study set out to compare captopril with losartan, and there was a smaller study, ELITE 1 study, which showed significant lowering of mortality with losartan compared to captopril. That was a smaller study, and it was designed initially to look for side effects of angiogenesis receptor blockers versus AC inhibitors in elderly patients, and improved mortality was an unexpected outcome, but it set out the tone for the larger LI2 study, which included around 3,000 patients, and losartan at 50 milligram per day, and enalapril, captopril 50 milligram TID were compared, and the compared outcomes were mortality, sudden deaths, and resisted arrest was the primary endpoint. And during the analysis of this study, there was a trend towards reduced mortality rate with captopril, and the superiority of losartan was not shown in this study. And the main thing that was incriminated in this study was the lower dose of losartan. But whatever the mechanism, we have seen that ARBs are not more effective than AC inhibitors in this population of patients. And tolerability or rate of adverse events, as you would expect, is less in patients with losartan. And for patients with AC intolerance, mainly because of cough, and occasionally because of angioedema, the role of ARBs was explored. And initially, in 2001, the VALHEFT trial was published, and subgroup analysis from that trial helped or it shed light on the role of ARBs in AC intolerant patients. And the VALHEFT trial, it set out to evaluate the addition of ARB valsartan on standard therapy, which consisted of AC inhibitors and occasionally beta blockers. And it was a large study as well, with around 5,000 patients, and the primary outcomes, mainly it is mortality, and additional hospitalization was considered as well. And these are the baseline characteristics. And as you can see in the background therapy, around 93% of patients were taking the AC inhibitor, mainly enalapril. And at the end of the study, there was no difference in mortality in patients who were taking combined valsartan with AC inhibitor versus the standard therapy of AC inhibitor only. But the combined endpoint of mortality and morbidity, which consisted of days plus hospitalizations, resuscitated cardiac arrest, showed benefits towards valsartan. And the subgroup analysis was done post hoc, and it showed the benefits of valsartan were mainly limited to patients not taking AC inhibitors. And this subgroup made up around 7% of the trial, and there was significant reduction in morbidity as well as mortality in this subgroup of patients. And as you can see, the outcomes were significantly affected by presence of baseline AC inhibitor and absence of baseline AC inhibitor, as well as beta blocker therapy. And with similar tone to this one, CHARM alternative trial showed the role of ARB in patients who are AC inhibitor intolerant. And the main reason for intolerance, as you can see from this slide, was either because of cough, angioedema, and the other side effects, hypotension, renal dysfunction. They seem to be shared by both drugs, but they were whether they recur or not in patients who take ARB was assessed in this trial. And candesartan was compared with placebo in this population. And as you can see, there was significant improvement in the combined endpoint as well as cardiovascular deaths. But you can see here the significant reduction in deaths or hospitalization for heart failure. And the recurrence of adverse events were analyzed based on the initial reason for AC inhibitor intolerance. And as you can see, patients who had hypotension, azotemia, and hyperkalemia, there was significant interaction for recurrence of adverse events. And patients who discontinued AC inhibitors because of cough and angioedema, the risk of recurrent side effects was not that significant. The other area that was explored was the combination of AC inhibitors and ARB compared to the standard therapy of AC inhibitors in this population. The premise being the helpful effect could be gained from complete blockage of RAAS, and as opposed to the ARB for angiotensin receptor blockers, AC inhibitors result in increased production of bradykinin and other vasodilators, and these vasodilators are thought to have beneficial effect in patients with heart failure with reduced ejection fraction, although we know that they also cause some of the side effects like cough, angioedema. And to this end, as I've already discussed, the VALIF trial was done, and it showed no benefits and even possibility of worsened outcomes with combined treatment. And the other trial was the CHARM Addis trial, which was part of very large the CHARM program, which encompassed 3 trials. And the CHARM Addis trial showed benefit of combining therapy with respect to both combined endpoints as well as with respect to cardiovascular death, as you can see in this picture. And with these 2 contradictory outcomes, the role of combining AC inhibitors with ARBs was evaluated in meta-analysis, which included these trials as well as other relevant trials with similar or a little bit different population. And this was a meta-analysis which was published in 2004, and it compared the role of ARBs versus placebo, as well as ARBs versus ACI, angiotensin converting enzyme inhibitors, and the combined RAAS inhibition with AC inhibitor therapy. And as you can see, these are the trials which are included in this study, and very large trials like the CHARM Added, the CHARM Alternative, the LI2, the Optimal, which was post-MI population, and Valiant, which was also post-MI population, were included in this study. And as you would expect, ARBs, when compared to placebo, for example, in patients who are intolerant to AC inhibitors, they showed significant mortality benefit, as you can see here. And when they are compared to AC inhibitors, there is a trend toward superior efficacy of AC inhibitors, though that's not statistically significant. And when we compare the combined therapy with AC inhibitors, there is no difference in mortality, but there was a significant improvement in hospitalization. But the role of dual RAAS inhibition and which agents to use for dual RAAS inhibition, whether to combine AC inhibitor with ARB or to combine AC inhibitors with aldosterone antagonists, was a point of debate subsequently, and multiple studies have shown that the improved outcomes with combining AC inhibitors with aldosterone antagonists, and the guidelines recommend the very restricted place for combining AC inhibitor with ARB, mainly in patients who cannot tolerate the aldosterone antagonists. Otherwise, there is no much place for combining ARB with AC inhibitors. And the third part is about aldosterone antagonists in heart failure with reduced ejection fraction. And the premise for evaluating spironolactone and other aldosterone antagonists was there was a phenomenon of aldosterone escape in patients who are being treated with AC inhibitors, mainly because of hyperkalemia, and the direct effects of aldosterone on the myocardium were elucidated in that same period as well, and the role of additional blockage of aldosterone antagonists beyond the standard therapy of AC inhibitors or ARBs was explored. And 2 trials were done to this end. The RAAS trial, which was more or less similar to the consensus trial in the form that patients with heart failure were included, and the emphasis trial, which was made up of patients with a milder form of heart failure. In the RAAS trial, as you can see, the patients were either class 3 or class 4, and in the past 6 months, they are required to have been in class 4 of heart failure. but during the start of the study, they may be in class 3 or class 4, which are severe forms of heart failure. And the primary cause, the primary outcome of mortality as well as combined outcome was significantly improved with spinal laptop. As you can see, there was around relative risk reduction of 30% by spinal laptop, which is a very high number. And adverse event-wise, as you would expect, there was significant gynecomastia or breast pain in men in the aldosterone group, and other side effects, hyperkalemia was numerically more common as well in aldosterone group. The other trial, the infant heart failure study, it was done in patients with milder forms of heart failure, and the background therapy, as opposed to in the RAAS trial, there was around 90% of the patients were taking both ACE inhibitors and beta blockers. So this trial also explored the role of the aldosterone antagonists in patients who are in standard therapy, using standard therapy for heart failure. And as you can see here, there are significant improvements in combined endpoints, as well as the mortality from any cause. And this established the role of aldosterone antagonists as an add-on drug on ACE inhibitors in patients with heart failure. The other explored treatment was combined RAAS inhibition with neprilysin inhibition. And in the earlier period, around 2000-2004, the role of omapatrilat was explored. And as we know, the omapatrilat was vasopeptidase inhibitor. It inhibited both the ACE inhibitor as well as the neprilysin, and beneficial hemodynamic effects were seen in smaller studies, animal studies. But when it came to trials for heart failure as well as hypertension, the rate of angioedema was significantly higher because of significant generation of vasodilator molecules with combined inhibition of ACE inhibitor as well as neprilysin system. And then came the phase of the ARNI, sacubitril valsartan, in which the angiotensin receptor blocker was combined with neprilysin inhibitor sacubitril, and thus AC, the angiotensin converting enzyme is not blocked, and this the generation of vasodilators like bradykinin is not affected, and the rate of angioedema and angioedema-like side effects was minimized. As you know, the trial was published in 2014, and it's a very large trial with around 8,000 patients, and the follow-up was around 27 months, and the trial was terminated early because of the superior efficacy of the new agent. And as you would expect, similar to the other trials in the RAAS drugs, patients at risk of azotemia, at risk of hypotension, hyperkalemia were excluded, and both the groups are matched for almost every feature, and background therapy, as you can see, is involved all the standard medications, including beta blocker, and also other drugs. And as you can see, there was significant improvement in the primary composite endpoint, and deaths from cardiovascular cause was significantly improved as well in this study. And Internisto was subsequently approved for use in patients with heart failure with reduced ejection fraction. Side effect wise, there was hypotension was more common in the sacubitril valsartan arm, but the other side effects were azotemia and elevated hyperkalemia were more common in the ACE inhibitor arm, and there was cough, angioedema. The difference was not statistically significant. And when we come to the dose of RAAS inhibitors in heart failure, two studies have shown that higher dose drugs, either be it either the ACE inhibitors or the ARBs, are more effective in preventing hospitalization, but mortality difference was not seen for both agents. These are the trials for as you can see, the Atlas study done on lisinopril, and mortality was similar in both groups, high dose as well as low dose, but the combined endpoint driven mainly by hospitalization was reduced in the higher dose group. And similar study was done for losartan, and people have used this study as an evidence for showing the equal efficacy of angiogenesis receptor blocker losartan if used in appropriate dose compared to ACE inhibitors, thus incriminating the lower dose of losartan used in the L-light and in the optimal studies for the inferior efficacy of angiogenesis receptor blocker versus ACE inhibitor. And the other population I will talk about is long-term RAAS inhibition for early post-MI LV dysfunction. These patients were excluded from all the studies we discussed earlier on, and then came the SAFE trial in 1992, and subsequently TRACE and AIR trials showed the benefit of ACE inhibitors in patients with post-MI LV dysfunction, and the role of ARBs compared to ACE inhibitors was explored in Optimal and Valiant, and the role of aldosterone antagonist eplerenone was established with a FSS trial in post-MI population. So as I said, because the patients with recent MI of MNs 2 or 3 duration were excluded from the previous trials, new evidence was required for this population, and the role of the RAAS system in early post-MI was not well established till this point. Though there were some hemodynamic studies of a smaller scale. So the SAFE trial, as I said, it was published in 1990. Patients received captopril 3 to 16 days post-MI, and patients had low ejection fraction, but no overt signs of heart failure or ongoing ischemia. And as you can see, mortality was significantly reduced by around 19% in patients taking captopril. And other outcomes, including heart failure, recurrent MI as well, were significantly reduced in this population. The AIR study was also a similar study, but the entry or the inclusion criteria was mainly clinical features of heart failure, as based on the physical examination or just X-ray, and imaging for low ejection fraction was not required as entry in this population. But this trial also showed similar benefit of ramipril in the post-MI population with LV dysfunction. TRACE trial was also of similar features, and in this population, LV dysfunction was confirmed by echo, and it is a single country study, and it also showed significant benefit of trandolapril compared with placebo in patients with post-MI LV dysfunction. And the role of ARBs, as I said earlier, losartan was studied in this similar population compared with captopril, and the dose, as you can see here, is the lower dose as well, and there was a trend towards superior efficacy of captopril compared to losartan, and subsequently very large trial, the Valiant trial, was done in this population, whereby valsartan, captopril, or their combination was compared in this population, and the trial consisted of around 15,000 patients, which is very large, and not in any of the outcomes in any of the groups, but there were more side effects in the combined treatment group. And thus, ACE inhibitors and in patients who are intolerant to ACE inhibitors, ARBs are the recommended therapy in post-MI LV dysfunction. And the role of aldosterone antagonists in this post-MI population was established with a FSS trial, which was published in 2003. These patients had low ejection fraction plus heart failure symptoms, or low ejection fraction plus diabetes, which makes them very high risk patients. And as you can see here, the days from any cause, the first graph, and days from cardiovascular cause or hospitalization for cardiovascular events, and sudden cardiac death as well were reduced with the aldosterone antagonists. And the other similar population for whom RAAS inhibition was studied where the role of short-term RAAS inhibition in all patients with MI, patients with or without elevated dysfunction, with or without signs of heart failure. And the role of RAAS inhibition in these patients were studied in very large trials, the ICIS-4, the GC3, the Chinese Cardiology study 1. These are very large trials, and all of them and the meta-analysis done on these trials showed benefit of AC inhibitors. The benefit is a bit lower compared to patients with post-MI dysfunction, but nevertheless there is significant benefit with a significant reduction in mortality. And as you know, because of these studies, AC inhibitors should be considered in all patients in the absence of contraindications in the post-MI population. And the other population with strong indication are patients with heart failure, early story dysfunction, diabetes, or anterior infarctus, which was shown to be a high risk feature, and AC inhibitor showed significant improvement in outcome in patients with anterior infarcts as per the ICIS trial, which was one of the ICIS-4 trial, which was one of the largest trials encompassing around 50,000 patients. And could RAAS inhibitors be helpful in preventing heart failure or other major adverse cardiovascular events in patients with stable coronary artery disease? This was also explored because we know that ischemic heart disease, recurrent infarctions, and pump failure is the main cause of heart failure in the population studied for heart failure. The role of these agents in preventing heart failure was explored, and the previous trials, SAVE and SOLVE, showed significant reduction in reinfarction rate, which is the cause of progressive pump failure and thus heart failure. And the role of these agents in patients with normal LV function and stable vascular disease or coronary artery disease was explored. And to this end, there are 3 very large trials: the HOPE, the Europa, and the PEACE trial. And initially, the HOPE trial, which was done with ramipril, and which was done in very high-risk patients who were elderly, who had evidence of vascular disease, mainly coronary artery disease, or diabetes plus other cardiovascular risk factors like hypertension, dyslipidemia, and the results of this study were significantly positive for all the primary endpoints, which were days, MI, stroke, and secondary outcomes, including heart failure, were significantly improved in this trial as well. So this study suggests that there is a place for AC inhibitors in preventing heart failure in this population. And the subgroup analysis showed that patients who are hypertensive or who have normal pressure, blood pressure, benefited similarly by use of AC inhibitors in this stable vascular disease population. And the Europa study also confirmed this improved outcomes in a bit lower risk patients. And subsequently, the PEACE study was done to confirm this. And this study differs from the previous HOPE and Europa studies because of the significant differences in background therapy, whereby these patients had lower average BP, were on statin therapy most of the time, and coronary vascularization was done in almost 3/4 of patients, mainly in their previous episodes of MI and the like, and this trial was negative. There is no difference in outcome. So though the patients are high risk, the level of risk was modified with treatment and with other treatments, mainly statin and revascularization, and that could be the reason why this study is negative. And to confirm this whether RAAS inhibitors can be helpful in patients with stable coronary arteries or not, a large meta-analysis, including the previously mentioned trials, was done in 2017, and you can see all the included trials are very large trials, and other, for example, Camelot, Imagine, the other important trials are included as well. And when we compare RAAS inhibitors with placebo, they significantly improve risk of developing heart failure, as you can see here in the meta-analysis. And when they are controlled, compared with active control, for example, like calcium channel blockers, they also improve the risk of developing heart failure, but they are not that significant. There is no significant difference in comparing other outcomes like reinfarction, stroke, or death. But towards the end of heart failure, there was a significant improvement in this population. And to this end, the guidelines recommend as a class 2A recommendation the use of AC inhibitors in this population if they don't have contraindication. The final thing that I will mention is role of RAAS inhibition in heart failure with preserved ejection fraction. And many trials have been done. For example, perindopril was explored in PEPS-HF. ARBs were explored in the charm-preserved, high-preserve, and aldosterone antagonists were studied in the ALDO, diastolic heart failure, TOPCAT, and ARNI recently was explored in the Paragon heart failure trial. But unfortunately, all the outcomes in these studies were negative, and a recent Cochrane library meta-analysis was done, and it also confirmed these findings, and there could be a reduced hospitalization with spironolactone, but overall, there is no drug with significant benefit in patients with heart failure with preserved ejection fraction. And that's all that's all I have for today. And thank you for listening.
Thank you very much, Dr. Mulualem, for the comprehensive presentation. And now the floor is open for questions from participants. I didn't see questions in the chat box, but if anyone wants to ask, you can raise your hand. In the meantime, I do have one question, Mulualem.
Okay.
It was really a comprehensive presentation. You addressed all the trials related to renin-angiotensin-aldosterone inhibition. Have you come across trials that show some clue about the contribution of RAAS inhibition in reversing remodeling? Nowadays, there are many drugs are coming for heart failure, though there is a significant improvement in the armamentarium, in the management. New drugs are also coming, but have you come across the RAAS inhibition in contributing for reversion of remodeling?
Yeah, some of the trials have subgroups for whom follow-up on LV volumes, ejection fraction were done. Among this, the SAFE trial is among this type of trials, and significant improvement in not only in LV function but also the size of the chambers, and other important systolic parameters were seen in these landmark trials as well.
Okay, yeah. Now the new markers of remodeling, in addition to the size of the ventricle, left ventricular in diastolic volume, in systolic volume, ejection fraction, the biomarkers are also contributing a lot in as a marker for remodeling, and one of them is BNP, persistent suppression of BNP. For example, the recent trial on prove heart failure on sacubitril valsartan showed a significant reduction in those patients having reduced early reduction of this heart failure markers. BNP do have a better improvement in left ventricular changes as well as ejection fraction. Any question?
Hello, good morning. I just wanted to give some comments and probably one question. So I just want to emphasize that even if combining ACE inhibitors with angiotensin receptor blockers in charm added has shown that there is a reduction in heart failure hospitalization and cardiovascular mortality by 15%, and cardiovascular mortality alone by 16%. That's in sharp contrast with the VALHEF trial, where combining valsartan in patients who especially were on ACE inhibitors and beta blockers had an adverse effect on mortality. But on the other hand, you can see that even if in charm added cardiovascular mortality was reduced, the benefit was neutral in charm alternative in patients who have intolerance to ACE inhibitors. So even if there is mortality benefit in charm added by about 16% cardiovascular mortality, and it's neutral in charm alternative, currently combining ACE inhibitors and ARBs, as mentioned by the speaker clearly, especially citing also other trials, is not recommended. I just wanted to ask, it has been suggested that you can probably consider combining these two very carefully in patients who are intolerant to mineralocorticoid receptor antagonists. So how do you make that assessment when you say that in patients who are intolerant or who cannot be on mineralocorticoid receptor antagonists, and how do you follow these patients? It's just a practical question. I mean, and we know that combining them could have adverse outcome in terms of hyperkalemia and renal impairment.
Yeah, as I said earlier, because of the trials you mentioned, the charm-added, the VALHEF, they were contradictory, and the other trials which compared the comparison, the combination of these drugs, like the Valiant and there are also the on-target trial as well. They showed no benefit and worsening of side effects, mainly renal dysfunction, hyperkalemia, I said, and hypotension as well in some of the patients. And close monitoring of the renal function test and electrolytes is recommended in these patients, particularly during initiation of these drugs or subsequently during dose increments in these drugs. And what's recommended is very close follow-up. Specific timelines for monitoring have not been published, but we need to monitor the renal function test and electrolytes very closely in these patients.
Okay, thank you. Probably one last comment is we have to always remember that when we cite these trials and try to implement them in our daily clinical practice, we have to remember that we have to use the trial doses of these medications. We often see patients who are on relatively low dose ACE inhibitors or ARBs or interest or the current based on the current paradigm, the recent paradigm trial, but we have to build on the doses of these drugs until we reach the trial doses of these medications with which benefit has been shown. So we have to make assessment every time patients come for follow-up and increase the doses as tolerated or until patients have unacceptable side effects. Your presentation was very, very nice and comprehensive, so I congratulate you on that.
Thank you.
So I didn't see the hands from the participants. Thank you, Mulualem, for the nice and comprehensive presentation. It was very nice. Have a good day.
Thank you, Doctor.